Let's go into urinary elimination. So again, there's going to be some pictures that I'm hoping that you've at least looked in a book. I'm not saying that you have to have a deep understanding of, but you've looked in a book. So for urinary elimination to be successful, all of these things need to be fully functioning. So coming from the kidneys, you can see that we come down to the ureters, to the urinary bladder, to the urethra, out to the outside world, wherever that may be. The main ones that we're going to cover are urinary retention, incontinence, infections, and urinary diversions. This person is in urinary retention. So I'm in urinary retention here. Apart from feeling bloated and not being able to go to the toilet and feeling uncomfortable, what could a possible subsequent issue be with being in urinary retention? If I've got urinary retention and my bladder is filling and filling, I'm either going to have some form of incontinence, which we'll touch on later. So I might kind of, involuntary kind of spill out. I might do damage to my bladder because I'm filling it up too much. Or I might have bladder go back up my ureters into my kidneys. So I might get some upper UTI or some kidney infections, which obviously are going to be much more harder to treat and are going to cause much more damage than just having a lower UTI. So urinary incontinence, the loss of voluntary control. So incontinence either through urinary or bowel continence. If you're incontinent, we've lost voluntary control for whatever reason. It's normally a symptom of something that's underlying. So sometimes we're not going to immediately treat the incontinence, but we're going to try and find out what is causing that incontinence and try and treat that one. Continence aids, we'll look at in a moment. So over here, we have urge incontinence. So we've got oversensitivity, possibly to infection or neurological disorder. And basically, it means that we can't hold on to our urine to get to the toilet. So it might be that we only know that we need to go to the toilet, 2 seconds before we desperately kind of, release everything. Stress. So this is caused by increased pressure in the abdomen. It could be through that we've had a sneeze or a cough. Someone who has just given birth or has had a child in the past. Over here, overflow. So as you can see from that picture there, I've got a full bladder, but for some reason, there's a blockage in my urethra. Who is affected? Males with enlarged prostates. So if you think of a big donut and your urethra goes through the middle, once that prostate gets enlarged, and it obviously impacts on the urethra being able to void, I'm going to get overflow. So it fills up and it fills up. I'm probably going to go into urinary retention. But because it fills up so much, there's going to be some involuntary leakage. The one under overflow is functional incontinence. Can anyone hazard a guess what that might be? The person that's had a stroke, they might have broken their leg, they physically can't get to the toilet on time. Mixed urinary continence is normally a mix of urge and stress. Nocturnal enuresis, this is clearly just a word just to make us sound a bit better. Does anyone know what we would call that? Bedwetting, yes. Now, whilst I've got a picture there of being catheterized, please make sure that you know that lower tract infections aren't purely because we've catheterized someone. But from a hospital point of view, this is going to be a major, major cause of lower UTIs because of something that we've done. And not necessarily that we've been unclean in the process, but it might be that that catheter has been there a little while. And remember, anything we put into a patient, be that catheter or cannula or NG, there's always the potential to have this lovely portal of entry to give some patient an infection. So urinary diversions, I'll be honest, and I've never ever seen a percutaneous nephrostomy. So you can see there that we put a tube into the kidney to drain out, to go straight into a bag. I've never seen one. To be honest, I think I've only ever seen 2 urinary diversions in my career. The one that I have seen is over on your right. You can see there that they've taken a little bit of the bowel and they've created a stoma for the ureters to go in. So that one you can see there is your ileal conduit. The one that I've seen was a urostomy. So they took the ureters and they basically had them come out of the patient's back. I had no idea what was wrong with the patient. They had a range of kind of developmental delays, but there was nothing to do with that. And none of us knew what to do with them. like at all. They looked like blowholes. And we had to somehow like think of a way to put a stoma bag on them. But funnily enough, because they constantly, if you think of how it normally works, your kidneys constantly drip urine into your bladder until it's full enough you go to the toilet. So trying to put a stoma bag on and trying to put an adhesive bag on when there was a continual drip coming out of the bag, we were there for ages before we decided just to put a load of blueies under the patient and just change it every half an hour. But that's the only diversion that I've ever looked after. And I can't say that urinary diversions, in my world at least, are very common. Bowel diversions, much, much different. So some of the factors influencing urination. So again, some of these are relatively obvious. So growth and development, for example. So obviously we're going to expect a 3-month-old to be completely incontinent of urine. The other thing with children as well is that they will, for their body size, they will urinate a lot more. The kidneys in children are immature and they aren't able to concentrate urine as well as you or I. So it means that when a child is urinating, they're probably actually getting rid of a lot more nutrients than you or I would, because we're able to concentrate our urine a bit more. So it could be muscle tone. I've given birth, I have relaxed pelvic floor. Not me, obviously. So some of the assessments. So this is probably one of the times, and with urination and bowel issues, is probably when you think of the patient first before you look at everything else. For these kind of things, it's probably not going to be an easy fix. It's probably not going to be, here's a pill, you're fixed. So we need to think of the patient holistically within this, find out how they're affected, because that might be much more important for us to work on than the actual issue. Because it might be we can't actually fix the issue. We can only fix the symptoms, and we can only assist the patient deal with the symptoms. So we need to find out the patient's quality of life. How is this affecting them? What are your patient's normal voiding patterns? It could be that, especially in the hospital, that all of a sudden a patient has to share a conjoined room. So they're sharing a bathroom. My son, he will not go to toilet at school. And he will wait, and it doesn't matter if he's got sports or anything after. The first thing he does is he runs into the toilet, he's there for about half an hour. I don't know what's the matter with the school toilets, but he is like, no, I'm not going anywhere but at home. Could you imagine if he was in hospital for 6 months and he had to share a bathroom with 6 other kids? Like how that would affect not just his quality of life, but his normal urination habits. Like that would be quite big, and that would be something that we would have to deal with. But how are we going to work that in with our patient so they feel a bit more comfortable? So pain, obviously that's something we can have an immediate impact on. Is the pain all the time? Is it when they're urinating? Is it after they urinate? Is it when they feel full? Is it when they feel empty? That's something we can have an immediate impact on. So when you talk about pain, how sore is it? What number is it? There's a raft of other questions that we're asking. Hydration. So we need to think about, okay, well, how is this affecting you? What impact does that have on? And what kind of things can we do to make this a little bit more bearable for you as a patient? We then come into, after we've looked at the patient, after we've looked at them individually and got their side of the story, that's when we're going to do a little bit more of a nursing and I suppose physical assessment. So I might have a listen, I might have a feel of their stomach, I might feel if they're distended. The last thing is that we're going to have a look at observe for discharge from the urethral meatus. Look, characteristics of urine is odour. I'm not expecting you to swirl this round in a glass. As you can see there, within a 2-hour period, if your urine output or your patient's urine output is less than half a milliliter, then they're obviously a bit of a concern. They're not urinating enough. You might want to talk to the doctor about if there is anything wrong, if there is any medications, or if the medication regime they're on is appropriate for them. Having said that, polyuria, so if they're peeing too much, so normally adults will urinate about 1.5 liters in a day. So if your adult is going for 2.5 liters in the day, then they're probably peeing a bit too much, and you want to try and find out what's the matter with them as well. With polyuria, and not so much in the hospital, but what would be a cause of concern, or what would be a condition that patients would come in with, and they might have days of polyuria? So basically, and again, we're not going to really cover diabetes, but they're drinking so much, but it's not actually going anywhere. It's just going straight through them. So polyuria is one sign that you should probably do a finger prick test on your patient. The main one that you're going to do is a midstream specimen. So if I was to tell you, I want an MSU off you, what would be the important things that I would need to tell the patient? What does that actually mean? So basically, you want to flush away whatever is in the initial part of the urethra. That goes into the toilet, then the midstream of your urine goes into the pot for testing, and then you can finish in the toilet. That's probably going to be the main one that you test, because a lot of the time when you test for a dipstick urine, which is that one at the bottom, that picture there that you're going to do, a lot of the time you always say, let's have an MSU, because there's nothing worse than going to a patient saying, can I have some urine? It wasn't an MSU, and that's really all pathology wants. And then going back to the patient saying, oh yeah, that one's contaminated, can we have another clean one? So it's always, you know, a lot easier to get an MSU straight away. For a child, if you're doing, I wouldn't say it's an MSU, it's more just a random catch, is sometimes you put a bag on the child, a bit like a stoma bag, which we'll have a look at, but it's just a self-adhesive bag that you put on. The problem being is that if it's there for any longer than really an hour, it's in a nice, moist environment, it's nice and warm, you're probably going to grow things on the bag. So when you get it, and the parents have been waiting for hours for this bit of this dribble of urine, and then you say, oh yeah, that looks like it's got something in, we're now going to need an MSU. So it's much easier if you're getting a child MSU to say to the parents, look, we're just going to have the nappy off, and you're going to have to sit and watch and wait with a specimen jar. Please make sure you tell the parents, please don't put any penises in here, because I've seen the amount of dads that will just sit the baby and just kind of just whack it on. That's clearly going to be the same as having a bag. You're going to grow lots of germs in there. I've seen parents that have been like waiting for like 6 hours. Like if anyone's got kids, you know that they just pee all the time until for some reason that you need them to pee, and you're waiting for 6 hours, and it'll be the one time that dad or mum looks away and then they turn around and there's a puddle on the floor. So please make sure, where you can, try and help those parents, because after 6 hours of looking at a penis or a vagina, desperately waiting for some urine to come out of it, they're going a bit crazy. Now, this one on the bottom here, this picture here is your bladder scanner. And this is one that if you go onto a placement, and I'm more thinking of 2803, which is your acute placement, you might see a bladder scanner. Please try and have a go at that one. It's basically like a really basic ultrasound, and you're really only looking at the bladder and how full the bladder is. If patients come in and they've got urinary retention, before you catheterize them, we want to know how much is in your bladder. Because if we kind of catheterize you without even knowing, and we get 500 mils and go, oh yeah, you're fine now, go home, but they actually had 2 liters in their bladder, then clearly we haven't done a good job. So that one is probably the only one that you're, as a nurse or even as a student nurse, are going to get to have a go at, but please have a go. Coming down into the invasive procedure, an endoscopy is any look into a hollow organ. So sometimes we talk about endoscopy in the bowels, we can do in the stomach. The endoscopy, we're really talking about the endoscope, which is the fiber optic camera. Angiography, what do you think that relates to? The first time I saw that, I was like, why is that in a urinary thing? Because angio, we normally think of as the heart. But really, in an angiography, what we're doing is we're normally looking at vessels in the kidney, because we're making sure that there is appropriate blood supply to the things that look after our bladder output. So planning. So what kind of things are we going to do? We've gone through assessment. We're trying to figure out what's not just the matter with the patient, because we might not be able to fix, but how is that affecting them? We're going to try and come up with some goals and outcomes. If you're coming up with nursing goals, what kind of goals are we developing? So we should be after SMART goals. What's really important here as well is that we don't come up with, and I suppose they're kind of timely goals, because we might just think of, right, well, our goal is that you're going to be fully continent. And that might be an end goal and that might be fine. But for the patient, that might be in 6 months. So we also need to think about short-term goals to make sure that the patient, A, has something to work on, and it doesn't, you know, it means that they're not going to have a horrible confidence for 6 months, because otherwise they're going to be like, right, well, that's my goal, but I can't do anything about it for half a year. Setting priorities, again, looking at our long-term goals versus our short-term goals, and continuity of care. So our discharge planning, when should be the first time we're thinking about their discharge? As soon as they hit your bed, you should be thinking about their discharge planning. The reason being is if you wait till the very end and then think, okay, well, I need to get these four different multidisciplinary teams involved, that might take you weeks. You should be thinking about that as soon as they hit the bed, because it's a good idea that those people come and see the patient, so when the patient leaves, they've got contact. So always be thinking about discharge as soon as the patient hits your bed. So implementation, so for this one, you can see that involving our patient education and health promotion is going to be the most important thing. This isn't going to be an easy fix, so we're really thinking about our patient being the forefront of everything we're doing at the moment. Please make sure you're really clear in any evaluation, any education that you give to avoid any confusion with what you're trying to give to your patient. Maintaining adequate fluid intake. It's going to be really, I suppose, really difficult for the patient to want to keep a normal fluid uptake, because they're going to be thinking, well, if I don't drink as much, this is going to be less of an issue. But that's going to have quite drastic effects on a lot of other things other than just their urination. I'm not going to worry too much about that one, because that's mainly looking at medications and you're not really going to have any direct input on that one. Mainly catheterization. You will at some point be involved in that one, but it's important to note that that's going to really vary depending on what hospital you go to. So some hospitals, for example, won't let nurses catheterize male patients. Only doctors can do that one because of the potential risk of damage to the prostate. The irony being, though, is that they will let any doctor do that. So it could be a junior doctor that is their first day on, never ever catheterized anyone before. So they're allowed to do it, but a 20-year-out nurse isn't allowed to have a go. So for anyone that hasn't seen a urinary catheter, so there's two types there. That first one is I'm just going to basically call an in-out catheter. So it could be, in my example of a patient waiting for 6 hours with their son or daughter, and they go, we still haven't got one. That's all we're waiting for. We need to find out if they've got a UTI to give them some antibiotics. It could be that we say, right, you've been here for 6 hours. Are you happy for us to do an in-out catheter? And it really is that we pop the catheter in, we get a sample of the urine straight from the bladder, and then we take the catheter out. The bottom one here is the indwelling catheter. And the reason that is, well, apart from there's two ends, is that there's going to be a balloon inflation port, because we need to keep that catheter in. And there's a picture of that in a moment. So you can see the balloon inflated there, but I'll show you a picture of it in the bladder in a minute. If you're going to do this, you need to maintain strict asepsis, because as I said, the potential of you introducing an infection to someone through a catheter is quite high. And again, it is going to be very dependent on the hospital that you work at, if you can do that, and if it needs to have a medical prescription. So as you can see on that picture there with the bladder, you can see that the balloon, so you put it in. Once you get some urine come out of the catheter, you advance it a little bit more into the bladder, and then you inflate the balloon with 5 to 10 mils of saline, and then you pull down to make sure it's in the bladder. The two different types of catheters, so I showed you pictures there that were your normal type of catheterization. The suprapubic catheter here, can you see that it goes through, so the yellow tube there is the catheter, it goes through the stomach, and it goes straight into the bladder. Now, I've had patients that maybe have, I think the patient I think she had spina bifida or something like that, and she had a permanent suprapubic catheter. So she had a fistula there that was made, and she could self-catheterize herself because it was much easier. She wasn't able to go to the toilet, and it was much easier than your traditional catheter that she was able to catheterize herself. On the suprapubic catheter, sometimes, especially with infants, you know how I spoke about waiting for hours and hours getting a urine sample? An infant's bladder sits much more closer to the abdomen. So sometimes, this is going to sound really cruel, but sometimes rather than go through the effort of having to catheterize them and the trauma that might cause to their urethra, is sometimes they do an SPA, or a suprapubic aspirate. So with a needle and a 20 ml syringe, they literally go through the stomach into the bladder and draw urine out that way. It sounds very cruel, but it's over and done with really quick, and you don't have to go through the trauma of holding the patient there while you're trying to jab them with a catheter. This one over on the corner, the urodome, the first year that I did this course from the Griffith College, there was a little girl at the front, and I could tell that she was waiting and desperate to ask me her questions. I could see the cogs were going, so I said, look, you want to ask me something, go for it. And she'd built up all that confidence to say, because I called it a condom catheter, she said, do I have to give my patient an erection before I put that on? Now, hey, that was a perfectly reasonable, I called it a condom catheter. She'd never seen one, she never knew. A perfectly good question. So anyway, I'm not going to say yes or no, but if I come to your placement and you are giving your patient an erection to put a urodome on, we're going to have words. That's all I'm going to say, okay? So please bear that in mind if someone hands you a urodome. So other implementations, so strengthening pelvic floor muscles. So I mentioned a little bit before of, for you ladies that are going to have babies, what strengthening exercise should you be doing? If you're sat there and you're bored, please practice your Kegel exercises. Self-catheterization, that might be for your patients that have a long history. So like I said, with the patient with spina bifida, she was taught to catheterize herself. My wife used to work on a spinal unit, and a lot of the patients who, depending on where their fracture was in their spine, they couldn't go to the toilet, but depending if it was low enough they could still use their hands, they would have to self-catheterize themselves because it's much easier. When we talked about that functional incontinence, their ability to get to the toilet, especially if they're out and about, would be severely hampered being in, to be a paraplegic. So being able to self-catheterize was much easier for them. So evaluation. Now this is really important because a lot of the time, especially with these things, remember how we spoke about the biggest thing for a patient is their quality of life. So the things that you implement really have to have an impact on that patient's quality of life. Otherwise, what's the point in doing it? It might be that you're never going to fix this urinary incontinence, so you need to think about your patient. So again, another picture that I'm hoping you've all seen before. And this one is clearly a little bit more involved than the urine system. There's a lot more involved in there. We're going to be looking, obviously, mainly, we're not worrying too much at the moment about the stomach, but the small intestine and the large intestines we're going to be looking at a little later. Now, this is another thing. See, this is why I like teaching, because there's always stuff that I learn for the first time. But clearly, if you're sat at an unhealthy 90 degrees while having a poo, we're all doing it wrong. So again, if you live at home, you say to your mum and dad, Danny said you have to buy me a step stool for the toilet, because that's where I'm going to do all my thinking as I relive these lectures. Unfortunately, look what we have, what, number 5 down? Another factor affecting bowel elimination is pregnancy. But we can see a lot of these are very, very similar to the factors that are going to affect our urinary elimination as well. So again, personal habits. Again, if you think of in the hospital environment, this is a brand new environment to we've just been admitted. Now I've got to kind of defecate in a place that's completely unfamiliar. Especially in a hospital, has anyone seen that even if you've got a nice private room, it's normally got a bathroom in the middle with 2 doors either side? I would just be completely paranoid that I hadn't locked both doors and someone's going to burst in on me as I'm got my feet up at 35 degrees. I would find that really uncomfortable. Also, if you imagine you've got your leg in plaster, you've got weights connected, so not knowing that I've got this issue and I've got to be in plaster for 6 weeks, but I'm going to have to poo in the bed as well. So some of the common bowel elimination problems, the one that look, a lot of these aren't going to be new to you, and you probably know all these words, so we don't really have to go over them. I do love the fact that flatulence has what sounds like a very professional type kind of description. Accumulation of gas in the intestines, causing the walls to stretch. Nothing about the noise or how funny it is, but that sounds pretty good. The impaction underneath, so results from unrelieved constipation. So hemorrhoids. Again, I showed my son what hemorrhoids were for the first time because he didn't believe me. And now he doesn't want to use the internet, so that's good. So there you go. If you've got if you've got teenagers that like to use the internet, just get those pictures up online. Just show them your PowerPoints for some of your courses. So bowel diversion. So again, we spoke about urinary diversion. I said they, well, in my world anyway, they're uncommon. You might come across a nurse that deals with them all the time. But bowel diversion's much more common. Now, you can see here, there's a few pictures of some stomas. And it's basically that some part of my bowel, and I'll show you a picture, has been brought through my stomach and has created a stoma. What that in essence means is I then have no control over when I defecate, because basically continuously, depending on where the stoma is, I'm basically pooing into a bag. And depending on where it is, that's going to be very dependent on what kind of things I use for the patient, what kind of education I'm going to give to the patient. So you can see here in the middle, so you've got an end stoma. So it could be that maybe I need to give my bowel a rest for whatever reason. And I bring a portion of the bowel out, and it might be that I leave everything in and I connect it after a couple of years. I've had enough rest, I've had maybe I've had radiotherapy because I've had some form of intestinal cancer. That's cleared, I can connect them, and hopefully I can use it as normal. A loop stoma is sometimes done in an emergency situation, that they basically bring the bowel in a loop out. They kind of put it, in my head I think of putting a pencil underneath, but I'm sure they use something a little bit more medical than putting a pencil underneath so the bowel doesn't go back in. And they cut it down the middle. So then you've got two ends. So you have one end that, well, and it's very similar to the double barrel, but the loop is done in more of an emergency situation. So one end will be for feces to come out, and the other end will be for mucus and things like that to come out as well, because obviously there's no point keeping, if you've got this bowel full of mucus because maybe there's something wrong with it, you don't want to just keep it in the abdomen. You need to be able to let that out as well. I'm not going to go too much into a cock pouch, mainly because I've never really seen anyone with it, so I probably wouldn't be able to give you too much information on that one. Now the picture here, we're obviously missing a small intestine, but from the large bowel, you can see all the different places that I can have a stoma. And you can see that on the top, so colostomy, which is going to be mainly on my large bowel, you can see how the stoma is quite flat, or relatively flat, compared to a urostomy or an ileostomy. The ileostomy, urostomy, so the one that's a little bit higher, that will be normally when I've had my small intestines brought to the surface. Why is it important as a nurse to know where that stoma comes from? Because surely it's kind of, you know, all stomas do the same thing. I'm looking after the stoma exactly the same. So why is it important to know whereabouts that comes from? Whether that's small intestine, large intestine. When we're changing that stoma, it's really important to know where along that track it is, because if we have, a sigmoid colostomy, that's very close to the anus. So the stool that comes out is probably going to be very similar to a formed stool that any one of you would do. If it was, however, very early on in the small intestine, what do we think the output of that stoma would be? What would it look like? It would be very liquid as well. If it was very early, just after the stomach and the gallbladder, what else would it be apart from liquid? It would be very acidic. And you can see there, that is why the bottom one for the small intestine is a little bit more raised. Because what that means is if you fit the stoma around it, hopefully it will come out of the stoma. There won't be any contact with the skin underneath because it's going to be quite acidic, it's going to be quite liquid. We need to make sure that the area around the stoma is going to be looked after as well. So the colostomy, is going to be quite formed. It's not going to be acidic. We don't really need to worry about having something that protrudes past the skin. But for something that's going to have gastric acid and is going to be quite caustic to the skin, we need that stoma to sit up a little bit higher to make sure that any output is going to go straight into the bag and not touch the skin. So as you can see there, there's a man looking very proud about his stoma. You can see here, this baby has got a slightly different stoma. So you can see at the top all the different types of stoma. You might have a one-piece stoma, you might have a two-piece. Now, the one-piece you can see over on the left-hand side You can see that, as I've just said, it is one piece. You cut the hole out and the whole thing gets stuck on. But remember, if it was very early in the small intestine, how often do you think I need to change that? Because it's continuous liquid. It hasn't gone through the bowel. It's not coming out fully formed. It's going to be a lot of times I'm changing that. So if it was from the small intestine, I would probably be good with a two-piece. So you can see over here, you see that little square? So over on your right. So the kind of anchor point will sit on my skin and the bag kind of clips into that. So what it means is if it falls up, I can just take the bag off and I can throw that away. And then I can just put a new bag on, because otherwise I would be having to take that off and on my skin. And can you imagine the damage that would cause if I was having to change that 20 times a day? That would be quite kind of uncomfortable. And once that breaks down so close to a stoma, you're in for a real high risk of infection. You can see that baby there has got a clear one. Any ideas why we might use a clear one? And we really only use a clear one at one point of a stoma process. I'm assuming that that baby has just had a stoma created. Now, if, like any surgery, we need to, as nurses, be keeping an eye on that post-surgery. It's not so much that we're keeping an eye on the stoma, but if it's just been put in, we need to make sure that there's a good blood supply, so we're keeping an eye on the colour of the stoma. We're keeping an eye on the consistency and what's coming out. But after a while, after we've gone through that kind of just out of surgery checks, that baby would then be able to go on to the normal pieces. And you can see there, I think 1, 2, 3, 4, 5 over, you can see a little infant one. And they normally have little pictures of elephants and stuff on. So the clear one is normally just because you have just had surgery and you've just had that stoma created. I can't see one on there, it's not a great picture, but they also might have a little bit of a charcoal filter at the end of the bag. Because if you've just had a stoma created, normally what happens is they normally inflate your bowel with air. So you're going to have a lot of flatulence that needs to go. And if you didn't have a valve on that plastic bag, you're going to go back and this plastic bag is going to be like, you know, like a scene in Up. He's going to be up on the ceiling. So you normally have a valve at the end of the see-through ones that you normally wouldn't have on the other appliances. So patient consideration. So remember, as well as the thing that we're doing, so we've had a diversion, for example, we need to really be thinking of the patient and how that's affecting them. Imagine if you had just been given a stoma, or you were told today, we need to remove some of your bowel, or we need to create a stoma and this is what's going to happen. How would you feel? How would you go through that process? You might be like that guy and you might be like, okay, well, you know, I can't do anything about it. I'll be proud of my stoma and I'll show whoever. I don't think I would be that comfortable straight away. I think that I would be very, very kind of, I mean, even more so. I mean, I know that I'm the physique of health at the moment, but I think that my body image would take a real hit by going through that. Some cultures and some people might see that as a form of mutilation, because now I've got something that was inside of me that is brought to the front. I'm defecating in a bag. Like, there's a lot of taboos that you're going to have to talk to patients with, not only about their body image, but how that's going to impact on them. What about if you had to talk about how people are going to have sexual relations when they've had a stoma? I don't think I would be comfortable in having that conversation. But can you imagine if, you know, on day one in your aged care, a little old lady says to you, I've just been told I have to have a stoma, and me and Bill next door, I don't know how we're going to have sex. How are you going to answer that question? So nursing history, you can see here that we're really copying very much so the nursing history that we're going to take for urinary issues as well. We're looking at history of exercise, the diet. Obviously, we were looking at hydration and fluid intake before. Recent changes. So again, that's really important to know, especially when someone's got a stoma, because just because they've got a stoma doesn't mean they also aren't going to become constipated or they're not going to have diarrhea. But if we don't take the effort to know where that stoma is and we have a watery discharge, we're just going to be like, oh, well, that's just normal for them. It might not be. Maybe they've got a bug. Maybe they've got diarrhea for something. Maybe they've got gastro or neurovirus. So please have a look and make sure that you take the time to get to know your patient, especially if they've got stoma and bowel diversions. After we've done that, we're obviously going to do a little bit more of a physical assessment. So mouth, why are we bothering to look at mouth? What specifically are we doing? We're thinking of the start of the GI tract. Is it that we need to fix something? Do they have nice mucosa? Is it moist? Is it red? Is there anything we need to do? The abdomen, maybe I need to palpate. Maybe I need to have a listen. PPE, I think Pan probably covered that in extensive detail, the amount of bugs that are going to be in poo. And fecal characteristics. And again, look, we have odour there as well. So this is where you're going to be using your Bristol stool chart. Now, I quite like the paediatric Bristol stool chart because there's obviously some... I think that looks a little bit more like Maltesers than rabbit droppings. But a bunch of grapes, corn on the cob, a sausage, chicken nuggets, porridge or gravy. So planning, again, we're following really almost to the letter what we've done for our urinary elimination. We're understanding what the normal elimination is, and that is normal for them. It's not normal in general, but if they've got a stoma, if they've got maybe something like Crohn's disease, what is normal for them? Because just because they might be abnormal with their output doesn't mean that that is going to be that all the time. They still might be constipated. They still might have diarrhea. We need to know what's normal for them so we can tell what's abnormal for the patient. Healthy diet, food and fluids. So again, just because someone is like me and they're a little bit huskier doesn't mean that I've got good nutrition. Especially if I've just had a stoma put in, I'm going to need much better nutrition. If it is very early in the piece, I'm probably going to need extra nutrition or extra dense nutritional foods because I'm not going to have all of my gut to absorb all the nutrition that I normally would have. Exercise comfort, skin integrity, especially with the stomas, and especially if it is an ileostomy, it's quite caustic when it comes out. We need to be looking at the surrounding skin. I'm not going to go on too much on this one because we covered a lot. We've mentioned cleansing enemas, look, digital removal of stool, that's something to look forward to. We've mentioned care of ostomies, cathartics and laxatives. We kind of use them interchangeably, but laxatives are going to be the more common thing and they have less of an impact on the gut. And understanding what normal defecation is. Now, you will all have to be, at some point, helping someone use a pan. So you can see the bottom one is a slipper pan that you would normally use for urine. The bottom one is the bed pan. And you can see here the first thing we need to do, now, bearing in mind that there's going to be lots of different patients and you can't do this with everyone, especially if maybe they've got C-spine precautions, we're not going to be able to roll them that easy. So you're going to have to think about, well, how can I do this with their issues or their condition? But normally what you would do is you would use two people, you would put them on their side, you would put the pan firmly under their buttocks, then you would roll them on their back. Please don't leave them on their back. Could you imagine how uncomfortable that would be to go for a poo while you're lying down? Please raise the head of the bed. So implementation, so when I've assessed my patient, I obviously need to put a plan of care in place and I need to do all these different things. Bowel retraining, to be honest, I don't think that you, especially as a student nurse, are going to be too involved in this. That's probably something, remember how we talked about the discharge as soon as the patient hits the bed? We're probably going to be needing to involve the stoma therapist. I would probably want to get the stoma therapist in there to help me with bowel retraining. Maintenance of fluid and food. So this is probably where I'm going to involve maybe a dietitian, nutritionist, and I'm going to be thinking about not just the food they're taking, but that it needs to be high in nutrition. Is there going to be any supplements they can take to make sure that this is going to help and maintain a good gut health? And promotion of self-concept. I don't think you as a nurse are going to be able to do this completely independently. It might be that maybe you recommend them to go and see maybe a counsellor or a psychologist, especially, again, we go back to the stoma. If you've just been told that you're going to have a stoma and it's going to be there for life, who would you prefer to see to be able to talk through your issues? It might be the nurse, but it's probably very unlikely that that nurse is going to have the understanding and the education to be able to guide you through that process. Your evaluation needs to focus not just on the goals that you want to do, but is that appropriate for the patient? Has it achieved what they need out of these goals?